So I've been dispatched to a 70-year-old male who's collapsed following an acute onset of central crushing chest pain. He's also had a near syncope and is feeling very dizzy. He initially presented as pale and clammy as well. He has a GCS of 11, which is made up of 3, 3, and 5. He's opening his eyes to voice, but is unable to obey commands. Initially, he was able to give us a history, but he's now declined to a verbal score of 3 just due to his confusion. So due to his presentation and his level of cardiovascular compromise, we also decided to lay this patient supine. Our patient has had an MI, which he had 5 years ago, but states that this time the chest pain felt really different from his previous one. He also takes silazepam and aspirin. So I have deemed this patient to be a status 1 and have also called for an R50. I've also taken a 12-lead ECG to confirm my diagnosis of conscious VT and to also rule out my differential diagnoses such as SVT and hypokalemia. So the ECG was showing wide complex tachycardia. Our patient also has a history of ischemic heart disease and is age 70, which kind of further increases our suspicion that this patient is likely to be in VT rather than SVT with aberrancy. Furthermore, SVT is less likely to cause severe cardiovascular compromise, and as per the St. John clinical guidelines, our patient is deemed severely compromised because he is unable to obey commands, he's hypotensive, and he's also at a high risk of cardiac arrest. So the patient's vital signs are as follows. He has a heart rate of 170, a blood pressure of 70/40, a rest rate of 18, a BGL of 7.6, and he has a temperature of 37 degrees. Hence, we are going to cardiovert this patient, and as previously stated, I've already requested an R50 to be on the way. As this patient is also unable to obey commands, we will not be administering ketamine. However, it would be indicated if the patient was alert and had a motor score of 6. So I've already set up my resus equipment, which is set up on the side here. So I've already got my airway adjuncts ready in case I need them. I've also set up the bag valve mask. I've got my oxygen set up, and I've also got the suction ready here as well. So I checked my patient's saturations, and he was saturating at 92%. So I popped him on oxygen, and I popped him on a non-rebreather mask, which I'm currently running at 15 litres per minute. I've also already gained large bore IV access, and I've gained this bilaterally on our patient, and I've also made sure that I've already got the defib pads on. So to mitigate the risk associated with cardioversion, we want to utilise the cardioversion checklist, which is on page 127 of the St. John Pocket CPGs. So I'm going to be going through this process now. So I've got my checklist already open here, and the first thing it says is to place the pads in either the apex sternum position, which they recommend, which I've already done for this patient. It also says, in addition to the ECG electrodes, I've already got a 3-lead ECG set up, but for the purpose of this Osce and due to the mannequin, I just can't place a 12-lead. So we want to ensure as well that the defib is in manual mode. I've actually already done this when I turn the monitor on. So I put it into manual mode and also selected 360 joules on the monitor as well, which you can see on the top right hand side. So we're doing this because our patient is an adult.
Check patient.
And I'm just turning those alarms off for the moment. So now I want to select a lead which has the most visible R wave present. So I'm going to do this now. And it's currently looking like lead 2 is going to be the most appropriate for this. I'm also not seeing any artifact on here either. So I'm happy with lead 2 for the cardioversion.
Check patient.
So now I'm going to be selecting synchronized mode. And I want to make sure that I am seeing one of the detection symbols above every QRS, which is the next point on the checklist. And I am seeing this, and this is really important that it is sitting on top of the R wave, simply for the fact that we want to minimize the risk of R on T, which could lead to torsades or cardiac arrest. So I'm happy with that. So the next point is if the patient needs any more sedation. So I'm just going to recheck our GCS because we didn't need any beforehand. Hi sir, can you hear me? Hi sir, can you open your eyes if you can hear me? Hi sir, can you hear me? So we've got no response to voice, touch or pain in the form of a trap squeeze. So I'm happy that the patient doesn't need any sedation because his GCS hasn't actually changed and he is unconscious. So as I already said before, I selected 360 joules, which I've already done. And now I'm going to be charging the defib and making sure that everyone is standing clear. I can't see anyone around my patient as of current. So everyone's standing clear. Standing clear, pressing and holding the shock button to deliver it. The energy's now been delivered. So I'm reassessing the rhythm here on the monitor, and I'm actually now seeing a sinus tachycardia, which means that the rhythm has been reverted. So after this, I do want to go back through my patient's ABCs, print off a 12 lead and treat as appropriate. If, however, the patient was still in conscious VT following on from that, I would also still be checking ABCs, also checking for a pulse, but I could consider re-cardioverting them again, as for a second time. I'd also make sure that I am using the checklist and going through the exact same process to do this. If, however, we did do a second cardioversion and this was unsuccessful, I'd be making sure that we are transporting the patient straight away to hospital and consider meeting back up en route. So I've been dispatched to a 40-year-old male who's fallen off a 6-metre roof. He fell into his concrete driveway and landed on his occiput. His neighbour actually witnessed this fall and stated that he was water blasting the roof at the time and he possibly just slipped and fell off. So our secondary survey has found a boggy patch, which is about 6 centimetres in diameter on the patient's occiput as well. The patient is currently lying supine and he's presenting as very restless and combative. He's opening his eyes in response to pain. He's also got a rigid extension of his limbs in response to this painful stimulus, and he's also moaning with irregular breathing. He also has some grunting respirations as well. Therefore, I'm giving him a GCS score of 6, which is made up of 2, 2, and 2. So the patient also has no medical history as far as I'm aware of. His vital signs are as follows. He's got a heart rate of 50, a blood pressure of 160 and 110. He's also got a rest rate of 12, but this is also irregular. He's got a BGL of 7.6 and a temperature of 37.0. So due to the patient having a motor score of less than 6, and due to the mechanism of injury being consistent with that of a severe TBI, I've requested an R50 with RSI capabilities to come and meet us on scene. We've also been advised that backup is 10 minutes away, and they have instructed me to carry out the RSI preparation checklist, which is set out in the St. John's Pocket CPGs. So whilst waiting for my backup to arrive, I'm also going to be treating my patient for severe TBI with the intent of preventing secondary injury in which damage results from subsequent brain swelling, infection, or cerebral hypoxia. This may result in the central nervous system's ischemic response, which is characterized by tissue edema, a raise in intracranial pressure, and the compression of cerebral blood vessels. Cerebral blood flow is then further impeded. Carbon dioxide accumulates, causing vasodilation, and also further leads to this increase in intracranial pressure and tissue necrosis, which is increasingly fatal for the patient. Furthermore, Cushing's reflex can also occur, which is a phenomenon that precipitates from a raise in intracranial pressure as well. A severe TBI can lead to brain compression, causing the cerebral hypoxia, and systemic hypertension will also develop to increase cerebral blood flow. However, this further exacerbates the increase in ICP, which leads to the eventual compression of the medulla oblongata and the vagus nerve as well. So hence all of this kind of induces the symptoms of Cushing's triad, which are hypertension, bradycardia, and irregular respirations as well. And these commonly indicate that an imminent brain herniation and death for the patient. All of these symptoms are also currently associated with our patient's current presentation. So due to the high mechanism of injury and high risk that our patient does have a C-spine injury, we have immobilized his C-spine just by placing towels on either side of his head. I've also got my airway adjuncts set up on the left-hand side here as well, so they're ready to go in case I do need to use them. I've also got my bag valve mask set up on the left, and we've got PEEP attached set at 5 centimeters of water. So if we do need to take over ventilations at any point, that is ready to go. So I also have oxygen running on my patient at the moment, and I've done this via a reservoir mask, and it's running at 10 litres per minute. This is because hypoxia induces a compensatory increase in cerebral blood flow and a subsequent worsening of intracranial pressure. The treatment is indicated regardless of the patient's SpO2 because of this. I'm also monitoring their blood pressure, and I've got the NIBP attached to their left arm there, and it's set to monitor it every 5 minutes. This is because cerebral autoregulation is impeded after a TBI, and in this setting, cerebral perfusion pressure becomes dependent on the systolic blood pressure, and hence a single episode of hypotension could actually be detrimental for survival. That's why it's really important that we do monitor that every 5 minutes. So now just going through the checklist on page 131, of my pocket CPGs, which is the preparation for RSI checklist. First things, I'm attaching nasal prongs without oxygen, which has already been done, and as I said, it's not actually attached to the oxygen yet. As I said before, I'm pre-oxygenating with the reservoir mask, which is running at 10 litres of oxygen per minute. As I said before, due to that risk of secondary insult due to hypoxia, that's there as well. Also have my BVM set up with PEEP set at 5 millimeters of water. I also have the SpO2 attached, I've got the NIBP attached, and I've got a 3-lead ECG on. For the purpose of this Osce and due to the mannequin, I can't put a 12-lead ECG on, but I would have done that otherwise. So capnography I've also got, and I've already calibrated it, and it's ready to go on the left-hand side there. I've also positioned the monitor so that it can be seen easily, and I've placed a towel under this so in order to do that. I've also ensured that there's a lot of space around the right hand side of the patient, so if the ICP needs to put their intubation gear, they're able to do that as well. I've also gained IV access, and I've placed that in 2 sites on the patient bilaterally and used a large bore to do that. So I've also prepared a running line of sodium chloride, which I drug checked with my offsider, so that is ready to go. But I'm not currently administering fluids to our patient, simply for the fact that they are hypertensive at 160, and we do want to titrate our fluid administration to a systolic blood pressure of 120, and they're currently over this, and this is a problematic for the reasons that I stated earlier. So I've also positioned my patient's airway for optimal airway prioritization. It's in the sniffing position, and I've got a towel under their neck currently. So we've also got the ETT holder set up here as well when it's under and it's ready to go. I'm also going to check the suction and ensure that it's working by turning it on and off, which it currently is. I also have the BVM, as I've said before, set up with PEEP attached there. And I've got a full set of vital signs that I've already written out, so these are ready to hand to the ICP when they do arrive. I've also updated the responding ICP through comms, and I've just let them know a general background to the patient's situation and a few vital signs as well, which I think are important. Because the patient isn't in an ambulance, I've tried to clear as much space as possible on each side of the patient so that whoever, whatever ICP or crew comes in has good access to the patient either side of them. So there's a high chance that intubation will fail, and in that case we do have a failed intubation drill which is set out in our CPGs, and this assists with reassessing and managing the airway for the second time. So if an ICP is unable to visualize the cords within the first 15 seconds, or they're unable to intubate within the first 30 seconds of the laryngoscopy, this is classified as a failed intubation attempt. The ICP in this case will remove the ET tube. They'll then manually ventilate with the BVM with the PEEP attached, and they'll also retry with the bougie. And this is when it's important for the RSI assistant really to know what is going on and what their individual role is and how they can help the ICP. So instead of using an introducer, the officer will instead use the bougie and may get you as the assistant to hold this in place. An ICP can also optimize the position of the airway. They can also consider using a different blade and may also get you to apply some anterior tracheal pressure. So if that fails and there isn't a EtCO2 above 5 centimeters of water in the first 2 to 4 breaths, then that is classified as the second fail. If a second fail occurs, the ET tube is then removed, and an LMA, MPA, or an OPA can be used instead. If these airway adjuncts, however, then fail and you're unable to successfully ventilate a patient, cricothyroidotomy will then be attempted by the ICP, who will make an incision through the cricoid membrane and insert the ET tube through there instead.